A 20 years old right-hand dominant college student presented for left wrist pain since last 5 months after close fracture treatment for distal radius fracture. The pain is on ulnar-sided and associated with activities, particularly those involving maximal extension or pronosupination against resistance. For example, turning a doorknob on a heavy door. There is no clicking. The patient injury had been treated in long arm cast for 8 weeks. Further notes revealed referring physician documents a diagnosis of distal radius fracture and a distal radio-ulnar joint dislocation reduced and treated in a close manner. The patient was referred for persistent ulnar-sided wrist pain. Now, this question can come in exam settings, and a differential diagnosis can be following. That can be ulnar styloid non-union, TFCC tear, ulnar carpal abutment, drudge incongruity, distal radius malunion, and ECU tendinitis. You further examine the patient hand, wrist, and elbow and shoulder, and was normal on examination. There was a minimal atrophy of the forearm musculature. Active range of motion of all joints was symmetrical bilaterally. There was tenderness to palpate radial to the ulnar styloid with the arm in neutral rotation and mild discomfort, but no increased translation or with stressing of the drudge. TFCC grind maneuver produces no pain or clicking. The ECU tendon did not sublux over its groove, and the wrist instability maneuvers caused minimal discomfort and no clucking. Neurological and vascular examinations were normal. Radiographs were obtained. A diagnosis, one of the most common diagnoses here is a TFCC tear. A patient coming up with a ulnar side wrist pain is a common complaint. Patient age, hand dominance, occupation are important historic findings, and the nature and the date of injury should be sought. Patterns of injuries have been associated with particular recreation activities. For example, hook-up image fractures with sport involving bat or club. Neurological complaints are common and should be sought. The differential diagnosis above is limited to the diagnosis likely after a distal radius fracture. Examination of TFCC is performed in conjunction with thorough examination of the wrist, elbow, and the hand, including neurovascular structures. Direct palpation of the bony and the soft tissue structures of the ulnar side to localize point tenderness is the most important examination maneuver. Tenderness radial or ulnar to the ECU tendon with a wrist in neutral rotation may be consistent with TFCC lesion. The drudge is examined with the patient's elbow on table in front of the examiner. The drudge is stressed with one of the examiner's hand grasping the distal ulna and the other grasping the radius. Volar and dorsal translation is assessed in neutral pronation and supination. A TFCC grind test is performed with the wrist in ulnar deviation and dorsiflexion with an axial load applied to the hand by the examiner as the carpus is rotated on the fixed forearm. Radiograph aid in establishing the diagnosis of a malunion of the distal radius or a non-union of the ulnar styloid. Fractures at the base of the ulnar styloid are more likely to be associated with the TFCC injury that will produce persistent symptoms if not treated. Ulnar carpal abutment is more likely in patients with ulnar positive or ulnar neutral variants. The term triangular fibrocartilage complex was originally used by Palmer and Werner for a group of structures that stabilize the carpus and the distal radius and fixed distal ulna. This complex includes the volar and dorsal radio-ulnar ligaments, ulnar collaterals, and ulnocarpal ligament, and the articular disc. The articular disc separates the carpal bones from the distal radio-ulnar articulation. The complex is central to three biomechanical functions of the wrist. Number 1, stability of drudge. Number 2, axial transmission from the carpus to the ulna. Number 3, ulnar-sided carpal stability. TFCC lesions are classified by Palmer in 1989 and was published in the Journal of Hand Surgeries. There are mainly two types of categories: as per classification of Palmer, either traumatic or degenerative. Type 1 is called traumatic and type 2 are called degenerative. They are further divided into different types. The traumatic type 1, A. Horizontal tear adjacent to the radius. B. Peripheral detachment of the ulna. C. Tear of the ulnar carpal ligament. D. Avulsion from the sigmoid notch. Degenerative are further classified into 5 types. Degenerative: A. Partial thinning of the articular disc. Type B. A plus chondromalacia of the lunate and ulnar head. C. B plus full thickness tear of the articular disc. D. C plus partial tear of the lunar triquetral ligament. E. D plus full tear of the lunar triquetral ligament and arthrosis. The recommended initial management of injured TFCC based on history and examination is 4 weeks of immobilization. The intimate relationship of the articular disc and the roots typically requires the use of the above elbow cast. At 4 weeks, patients are begun on the range of motion and strengthening exercises and progress as tolerated. Surgical management is indicated for failure of conservative treatment. Degenerative lesions are more common in patients with ulnar positive variants. Recommended initial treatment include activity modifications, splinting, non-steroid medications. Surgical intervention indicated in the conservative management fails. Surgical treatment of the lesion of the TFCC continues to evolve. Traumatic lesions are typically classified at the time of diagnostic arthroscopy. Wrist arthroscopy is performed within wrist in 10 pounds of traction to facilitate visualization of the TFCC. The portal for visualization and manipulation of TFCC include 3-4, 4-5, and 6R portals. 1A or central lesions are most common traumatic lesions seen. Traumatic arthroscopic debridement of the unstable edges of the tear is typically recommended. Cadaveric studies have demonstrated that excising the central 2/3 of the articular disc does not alter the biomechanical function of TFCC. Postoperatively, patients are encouraged in immediate mobilization. Return to work or athletics usually is within 6 to 12 weeks. Diagnostic arthroscopy of this case demonstrates to be a stage 1B lesion. The finding of a peripheral detachment to the TFCC is not always as obvious at arthroscopy as one might anticipate. The helpful diagnostic maneuver is a trampoline sign that is elicited with the probe in 4-5 portal and the arthroscope in the 3-4 portal. The elasticity of the articular disc is tested with the probe, and a positive test is the loss of normal tissue toughness. Peripheral tears are through the vascular zone of TFCC and are typically repaired. A variety of techniques have been described, including open, arthroscopic assisted, and arthroscopic technique. A small incision is made just ulnar to the ECU tendon, and a blunt dissection is performed to isolate and protect the dorsal branch of ulnar nerve. 2. Twohy needles are used to penetrate the wrist capsule and the articular disc in the appropriate location, and a horizontal mattress suture is used with 2-0 non-absorbable sutures in an outside to in technique. 2 or 3 sutures are placed and tied over the capsule. Postoperatively, the patient is immobilized for 4 to 6 weeks in a Munster cast to eliminate rotation of the forearm, and additional 2 to 4 weeks in a wrist splint. Return to full activity is allowed in 3 months. One of the controversial treatment of type 1C and 1D TFCC injury has not received as much attention as the more common injuries. Classically, it is believed that the radial detachment would not heal and were debrided to stable edges if there was not a bony fragment attached to the articular disc. Recently, open arthroscopically assisted repair of avulsion of TFCC from the sigmoid notch, that is 1D lesions, have been described, but outcome data is limited. Distal lesions 1C are the least common injuries pattern described in most series. Whether debrided or a repair of 1C or 1D lesion is superior is unclear at present. Treatment of degenerative lesions of the TFCC depends on power classification and staging. Lesion classified as 2A or 2B are typically treated non-operatively with anti-inflammatory medications, splintage, and activity modification. An extra-articular ulnar shortening or an intra-articular wafer procedure with removal of 2 to 4 mm of distal ulna can be considered in unusual cases of symptoms refractory to these measures. If the lesion has progressed to stage 2C, a TFCC debridement is performed. If the patient is ulnar positive, this may be combined with wafer procedure. Stage 2D treatment includes the ulnar shortening and treatment of wrist instability if it is substantial. And a stage 2E may present with substantial degeneration of ulnar carpus and typically require salvage procedures.